Dr. Kigondu?
Yeah, I was looking for the slideshow button. This one has no slideshow button. 1 second, let me pause share, chat, slideshow. Okay, 1 second.
As Dr. Kigondu prepares, just to echo what Enoch said earlier, if you have any questions in between, please feel free to put them on the chat. Yes, and we'll also have a question and answer session at the very end of the presentation.
Enoch, has the slideshow come?
No.
Not yet.
You will have to share screen again, sir.
Volume.
Yes. It's visible, Dr. Simon.
Oh, thank you very much. I think we'll go on without much further ado. We have, sorry about that. We have a short period of time, so we'll go straight to the subject matter. So our outline is that we'll do the labor definitions and mechanism of labor. And labor is a physiological process which begins with, which eventually ends when products of conception are expelled outside the uterus. During labor, there are changes in the biochemistry of the connective tissues that eventually leads to the gradual effacement and dilatation of the uterine cervix. This results from rhythmic uterine contractions that are of sufficient frequency, intensity, and duration. So the important thing to note about labor is that it eventually leads to the products of conception, being the baby and the placenta, being expelled out of the uterus. And this starts with changes that are biochemical in nature in the connective tissue. Of importance, again, the gradual effacement and dilatation of the uterine cervix. So labor is its onset is of regular, painful uterine contractions. These eventually lead to a progressive cervical effacement and dilatation. Why that is important is that if you have cervical dilatation without uterine contractions, that can be considered cervical insufficiency. On the other hand, if you have uterine contractions without cervical change, that may not be labor, and you may need to look for other causes of uterine contractions. The stages of labor is generally a continuous process, but for purposes of definition, 3 stages have been delineated as the milestones of labor. And these are famously known as the first stage, second stage, and third stage. There's even a 4th stage, but that happens after the baby is already out. During the first stage of labor, the first stage of labor starts with regular uterine contractions, and it ends with a complete cervical dilatation, which is normally referred to as 10 centimeters dilatation. The famous study by Friedman, where he studied 500 nulliparous ladies in labor, famously divided the labor into a latent phase and an active phase. The latent labor of first stage is characterized by uterine contractions that are, they start as mild pains and they are irregular. The irregularity of it all is a very good characteristic of latent labor. As these progressively become more rhythmic and stronger, then they start having an effect on the cervix. And the effect of the cervix is to soften the cervix and shorten the cervix. Labor and delivery is very simple. If the cervix is closed, the baby cannot come out. If the cervix is soft and open, then the baby can come out. The active phase of labor is described as starting from about 3 to 4 centimeters of cervical dilatation. It progresses with rapid cervical dilatation and a descent of the presenting fetal part. The active phase of labor ends at complete cervical dilatation of 10 centimeters. In between there, during the Friedman studies, where he studies nulliparous, the active phase, he divided the active phase into an acceleration phase, a phase of maximum slope, and a deceleration phase. I'm sure a majority of us who have participated in delivery have noticed these phases. Sometimes you can have a phase where the labor is moving very fast, and then a time when the labor then decelerates. That was described by Friedman in what is famously called the Friedman labor curve. And this demonstrates average cervical dilatation. And with that curve, he provided a series of definitions of labor protractions and labor arrest. He tried to frame the progress of labor and describe when labor has become protracted or arrested. The second stage of labor starts with a complete cervical dilatation and ends when the fetus has been delivered. Second stage of labor can be reported to be prolonged If it takes more than 2 hours, when there is no regional anesthesia for nulliparous, and when it takes more than 1 hour for multiparous women. In places where they use regional anesthesia, if the second stage goes for more than 3 hours, then it's considered prolonged for nulliparous and 2 hours for multiparous. And the risk factors for a prolonged second stage include being nulliparous, increased maternal weight, the use of regional anesthesia, induction of labor, and occipital-posterior or occipital-transverse position, and increased birth weights. These are factors that you need to look out for during second stage, so that in case the second stage becomes prolonged, you will have anticipated it. The third stage of labor starts with delivery of the fetus and ends with delivery of the placenta and fetal membranes. The process starts with a uterine contraction, and there is decreased basal blood flow. Then the surface area underlying the placenta thickens, and there is a reduction of that surface area. And then you have a detachment of the placenta. Generally, can take about 1 to 30 minutes. Longer than that, then you would need to have intervention. The way of managing that stage of labor can be via unexpected management. You wait for the placenta to come, or active management, where you administer uterotonics, you clamp the cord, you have controlled cord traction and delayed cord clamping. Prolonged third stage can be assessed after 30 minutes, and the placenta is still not come out yet, and an active intervention such as manual extraction of the placenta may be necessary. So normal labor can progress at a rate much slower than what Friedman showed. These are challenges to the regions from which you are looking at. In your facilities, what is the average interval of progress from 4 to 10 centimeters in cervical dilatation? Have you collected this data? What are the median lengths of first and second stages of labor in your institutions? And what maternal characteristics or obstetrics factors are associated with the length of labor? And should home births be carried out? These are studies that you can perform in your places of work. The mechanisms of labor are also called cardinal movements. Labor, as I reported, is continuous, but it has been described as 7 discrete sequences. And these are vertex presentation, which occurs in about 95% of the delivery. The ability of a fetus to successfully negotiate through the pelvis during labor involves a change in the position of its head during passage in labor. And maybe we might need a reminder of how the human pelvic bone is. And in front there, we can see the subpubic angle, the left and right pubic bones. You can see the pelvis, you can see the coccyx and the sacrum behind there. And note the symphysis pubis is important during labor and delivery. The boundaries of the pelvic outlet are shown. This is the typical scenario when you are doing a delivery of a baby. And of importance, I want you to note the 11 centimeters, that is the diameter between the what are called the ischial spines. Yeah, and you can see the AP diameter is 13 centimeters and the diagonal centimeter of 12 centimeters. But of importance, of note, is the ischial spines and the diameter in them. The intraspinous diameter, as you see the lower blue line, is the narrowest part of the pelvic outlet. The ischial spines are therefore very important landmarks during labor and delivery. And as you're measuring the baby, then it's important to remember the landmarks of the fetal skull. And you can see, just as a reminder, there you have the frontal bones, the temporal bones, and the parietal bones, and you have the face in front there. In front there is commonly called the anterior fontanelle. The posterior fontanelle is at the back, and in between there you have the sutures. At the front you have the frontal suture, and of note is the 9.5 centimeter, which is the widest diameter during labor and delivery. So note this for the discussions that we'll have later. So the 7 mechanisms of labor include engagement, descent, flexion, internal rotation, extension, restitution and external rotation, and expulsion of the fetus. And engagement is when you have a well-flexed head with the largest transverse diameter of the fetal occiput, also commonly called the biparietal diameter, engaging, entering into the maternal pelvis, and it just goes below the pelvic inlet. On pelvic examination, you will find the presenting part at what is called station 0, which are the ischial spines that I showed you in the pelvis, the ischial spines, the blue line. So this is shows a picture of engagement. As you can see, in between the pubic bone at the front and the sacrum at the back, the baby has entered into the maternal pelvis and is now descending. A view from the bottom shows the fontanelle, as has been described, the anterior fontanelle and the posterior fontanelle within the pelvic cavity. As after the baby has engaged, then the baby travels downward through the pelvis. So this occurs with contractions. So when the mother has contractions, the baby is pushed downward through the pelvis. The rate of this is highest during second stage. And I think a lot of you may have noticed that during second stage, you find the baby coming down in a faster descent. Flexion is caused by resistance to the fetal vertex on descent. So the baby goes down, finds the bony pelvis and the soft tissues of the pelvic floor, and is forced to flex at the neck level. You get passive flexion of the fetal occiput, and the chin is brought in contact with the fetal thorax. The presenting diameters now change from what is called occipital frontal, which is about 11 centimeters, to suboccipital bregmatic, 9.5 centimeters, which is optimal for passage of the baby through the pelvis. And that is that you can see the baby's chin is on the neck, and you have the suboccipital bregmatic and positioning diameters, which now are 9.5 centimeters to allow the baby to go through. As the baby descends, the head usually descends in an occipital transverse position. As you can see there, the baby has the occiput in an occipital transverse position. And as it reaches the symphysis pubis, then it is rotated to the what is called the anteroposterior position. The anteroposterior diameter of the head is brought in line with the anteroposterior diameter of the pelvic bone. What does that mean? As you can see, the baby's head is right under the subpubic arc, and the baby's back of the neck has just gone below that, and the fetus, the shoulders of the fetus have entered the pelvis in a transverse direction. So the baby's head has to rotate in order to accommodate the position it is in. After further descent and the head is fully flexed, the base of the occiput contacts the inferior margin of the pubic symphysis. Upward resistance from the pelvic floor and downward forces of uterine contractions extend the occiput and rotate it around the symphysis pubis, and then the head is delivered. As you can see, the baby has extended, meaning that it is almost facing the person conducting the delivery. But it is important to also note that the shoulders are still rotated at 45 degrees away from the baby's head. And as a result of that, the baby's head, once free after coming out, turns around another 45 degrees to be in line with the shoulders. And that movement is called restitution or external rotation. And it is basically returning to its original anatomic position. Once the baby continues to descend, and the anterior shoulder, as you can see, is the one that comes just below the pubic symphysis. It is then rotated under the symphysis pubis, and this is then followed by delivery of the posterior shoulder, and the rest of the fetus follows. So when you're taking a history of a mother who has come in labor, you need to review the prenatal care, confirm the expected date of delivery. We have seen people who may have come with the wrong EDDs, and it's important so that they do not end up having preterm deliveries. You take a focused histories concentrating on the contractions. What is their frequency? What is the time of onset? Are the membranes ruptured? Is there amniotic fluid that is clear? Is it meconium stains? And is the baby moving? Presence or absence of vaginal bleeding is important because it can constitute either antepartum hemorrhage or it can be show. A lot of times it's important to distinguish between true contractions and what are called false labor or Braxton Higgs contractions. The characteristics of Braxton Higgs contractions or false labor is that they are irregular, they do not increase in frequency and intensity, and they often resolve when you ask the mother to walk around or change her activity. They occur occasionally. They can occur 1 or 2 per hour, and they can occur maybe a few times in a day. It is important to differentiate this from true labor, because if you diagnose Braxton Hicks contractions as true labor, then you are likely to do an unnecessary cesarean section because of admitting mothers too early when they are not in labor. True labor lasts longer, the contractions, they are more intense, and more importantly, they lead to a change in the cervical, in the cervix. So as I had said, the contractions, they are persistent. They may start infrequently, but they keep increasing, and they start from 10 to 15 minutes, and then they increase to 2 to 3 minutes. If the contractions occur without cervical changes, then you may need to look for other causes of contractions, like maybe urinary tract infection, cervicitis, or other. Lightening is a physical change where the mother feels like she has become lighter. This is as a result of physical changes as the head of the fetus advances in the pelvis. The shape of the mother's abdomen may change, and the breathing of the mother may become more relieved as what was causing tension on the diaphragm has gone down. The head may push on the urinary bladder, and urination may be more frequent. So when the mother is with you and you are doing a physical examination, it's important to take vital signs. Then you measure the fetal well-being, and you assess the uterine contractions for frequency, duration, and intensity. And then comes the famous Leopold Maneuvers, which are meant to assess positioning of the baby. And they're described as 4 maneuvers. And the first maneuver is as shown in the diagram there, where you're looking at the fundal area. Your hands are in the upper quadrant. You palpate the fundus with both fingers, and you define where the fetal pole at the fundus is. So you will check whether there's a head there, the breech, or if the baby is transverse, you may not find much. Then the second maneuver is aimed at determining the position of the fetus. So you place your hands, deep pressure in the para-umbilical regions, and you differentiate between and the back. As you can see, the hand to the extreme right is touching on the back, and the limbs are on the left. And you are able to tell the baby's position. For instance, this particular fetus is in left occipital transverse position. The third Leopold maneuver is where you do suprapalpation with the thumb and the fingers of the dominant hand. This way you are ascertaining the fetal presentation, like in this particular picture, is cephalic. And you also estimate the station. Is the baby has some form of engagement? And its balance assess. A hard round mass would be the head. A soft mass would be maybe breech. You are also able to assess the volume of amniotic fluid, and you can also assess the fetal weight using this maneuver. The fourth maneuver is where you palpate bilaterally the lower quadrants to determine engagement. You stand facing the mother's feet, and with the tips of your first 3 fingers of both hands, you put deep pressure as shown in the diagram. And if it's a cephalic presentation, you will say that there is engagement if your fingers do not touch each other. They diverge as you trace them to the pelvis. When the mother is with you now, you perform a pelvic examination using sterile gloves. If membranes are ruptured, you can use a sterile specula to confirm if it's pulling. This is especially done if it's a premature labor. And there are other tests for people who are not sure if it's amniotic fluid, nitrazine test, litmus tests. If there's frank bleeding, you need to exclude placenta previa. You can do an ultrasound and also assess the pattern of contractions and the history, so that you're able to differentiate between abruptio placenta, which is a separation of the placenta leading to bleeding, and placenta previa, which is the placenta being in a position other than where it is supposed to be at the fundal area. When you do a digital vaginal exam, then you can assess the cervix, a very important assessment. As shown in the diagram below, cervical dilatation can be assessed, which can be between 0 to 10 centimeters, which is full dilatation. Cervical effacement can be assessed, and it's reported either as a percentage of the normal cervix length, or you report it as the actual cervical length. And this is less ambiguous, meaning that if you say the cervix is 2 centimeters long, then the next person can report if the cervix is 1 centimeter, then you say there is improvement. You can also assess the position, which can be anterior, posterior, central, and the consistency of it, which can be soft and firm. The famous Bishop's score is the one that is used to assess, to see whether the cervix is ripe, to be able to assist in assessment of progress of labor. You can also be able to assess via digital examination the presenting part. As you can see, you can tell if the presenting part is at -5, 0, or +5. That is relative to what we call the maternal ischial spines. 0 is station is the line in the plane of the maternal ischial spines. As you can see, the person doing a digital vaginal exam is able to touch the sacral promontory, is able to assess the baby, is able to assess the cervix. Yeah. Then, as we said, pelvic assessment can be done either clinically or radiographically. Radiographic assessments can be done by either X-ray, CT, or MRI. And these are mainly done for people who, for instance, would want to do, for instance, a vaginal birth after cesarean section, so to speak. And there are various planes that are described as a pelvic inlet, diagonal conjugate, transverse diameters, mid-pelvis, and pelvic outlet. And it's much easier to visualize this by looking at this diagram where you have the inlet, which is if between A and A1, that is the inlet. These are diameters that you want to be adequate. Then in the mid cavity, you have the mid cavity. Enoch, am I audible? I'm seeing one or two people saying the sound is a bit down.
Dr. Simon, you are audible.
Okay, thank you.
Okay.
I think it's their gadgets. So if someone may find they are not hearing very well, they may look at their gadget. All right. So that the cavities, then the outlet is you have the anterior and transverse positions. There are certain figures that you want your diameters to be able to have a delivery without any problems. So what do you do when you're preparing for labor and deliveries? You must evaluate all pregnancies as if they are high risk and they must be followed up closely. On arrival, the mothers can be done external tochometric monitoring from the onset and duration of contractions, and a Doppler device may be used to detect fetal heart tones. In our regions, we use the PNAD fetoscope a lot. A lot of the areas, I'm sure, have that, but it is important to have one of those Doppler devices because of its advantage of being able to hear fetal hearts, and also the mother can hear the fetal hearts and everyone around, so that you have some form of objective assessment. Tochometric, we usually use our hands as the tochometers, but there are machines for doing tochometry. This is where you place your hand and say that this contraction is lasting 40 seconds and it has lasted 1 minute. And that's the way you can classify it. In slightly advanced areas, you can have external tochometry, which records only the timing of the contractions. And internal tochometry is where there are ruptured membranes, and you may want to determine the onset, duration, intensity of contractions, and where intrauterine pressures generated during uterine contractions can be measured. These are not very common in our regions. Cardiotocography is where we want to move to, where you have electronic fetal monitoring. Cardiotocography has been compared with intermittent auscultations with our PNAD fetoscope and also with the Doppler machines during labor. And this has been associated with good neonatal outcomes. It reduces neonatal seizures. It has been associated, but it has not necessarily been associated with a reduction in cerebral palsy or infant mortality. In some areas, they do continuous monitoring, which has been associated with an increase in cesarean sections. Continuous monitoring is done where you have suspected that there could be some form of fetal distress that is coming up. But generally, intermittent auscultation is what we use in our labor wards. For those who use fetal scalp electrodes for non-reassuring fetal heart rate tracings, they may be applied to generate sensitive readings of beat-to-beat variability. They are contraindicated in infectious diseases of HIV, hepatitis B and C, and where fetal thrombocytopenia is suspected. Now, Intrapartum management of labor in the first stage of labor. Latent labor, the cervical changes are slow and gradual. Latent labor is complex. It's not well studied. And often the determination is subjective, as I'm sure you will give me feedback from your areas of working. And it may be challenging for women as the assessment is they assessed at different times, different cervical dilatations. Yeah, 8% of term pregnancies may be complicated by a rupture of membranes prior to labor, commonly called PROM. The rate of cervical dilatation, Friedman put it at 1 centimeter per hour at the least for nulliparous women and 1.2 centimeters per hour in multiparous women. However, as you have noticed with management of labor, this has changed substantially during the last quarter of a century. We are now even allowing labor to continue up to 6 centimeters dilatation to reduce the rate of intrapartum and subsequent cesarean deliveries, as is being seen in the pathograms that are being produced nowadays. When the patient is in view, they need to be allowed to assume a comfortable positions, and the patient and her family and support team should be consulted regarding the risks and benefits of the various interventions. A lot of times we just augment labor without informing the mothers. We need to inform mothers when we are having augmentation of labor, when we are doing, for instance, artificial rupture of membranes, and when we are offering pain relief and control, and when we are offering operative vaginal delivery like a vacuum or cesarean section. It's good to explain to the mothers what you are doing. The monitoring of labor has changed over time, and I've just put there 2 pathograms, one that was used previously and one that is used currently. As you can see, the previous pathograms used to have a latent phase, and they were starting at 2 centimeters, and from 3 centimeters is where the active and alert lines were starting. But with time, we have a modified pathogram where we do not have a latent phase, and I'm hoping that all of you are now using this modified pathogram. And we have allowed labors to start later than 2 to 3 centimeters. They start at about, you give them at 4, and even we are even moving to saying that labor needs to start being pathographed at 6 centimeters to avoid what we have famously known as the pathogram page 2. And that becomes a diagnosis for cesarean section, whereby it is as a result of probably starting the pathogram too early. So you monitor the frequency and strength of uterine contractions, changes in the cervix, changes in the fetal station and position. These are assessed periodically. Vaginal examinations are only done when necessary. And if they are to be spaced, we do them 4 hourly. During the first stage of labor, the fetal well-being can be assessed. You can do 30 minutes, every fetal heart every 30 minutes. And you can also repeat immediately after contractions to try to detect what are called decelerations. In some labor units, the fetal heart may be monitored continuously, especially in mothers that you are worried about fetal distress. Augmentation, the use of low-dose syntocinon with long intervals is the traditional method of augmentation, where you have uterine contractions that you don't think are sufficient. Then low-dose infusion of syntocinon can be started at 1 milli international unit per minute, and it's increased by 1 milli international units per minute every 30 minutes until you get adequate contractions. Adequate contractions are described as 3 strong contractions in 10 minutes. In our units, we famously use 5 international units of syntocinon in 500 mils of normal saline. And normally, a lot of protocols start at 10 drops per minute. and increase half hourly till you get 3 strong contractions, or you reach a maximum drip dose of 60 drops per minute, which, if contractions are still not yet strong, you increase the syntocinon to 10 international units, and you start at 30 drops per minute. Sort of 5 times 60 is equivalent to 30 times 10, and you continue increasing as per until you get good contractions. Other people have short methods of optimizing. They shorten the labor and they want to optimize uterine contractions. They do hourly cervical examinations and early diagnosis of inefficient uterine activities if the cervical dilatation is less than 1 centimeter per hour. And they use high dose oxytocin, which they increase every 15 minutes. This is not a very common augmenting strategy, especially in our region. A lot of times, as we use the traditional method. Labor dystocia is when you have abnormal labor. It's famously grouped into abnormalities of power, which refers to uterine contractions or maternal expulsive forces. And augmentation is sorts that out. The passenger, where the position, size, and presentation of the fetus can sometimes cause dystocia. Famously, a lot of prolonged labors, for instance, would be as a result of the persistent occipital posterior position or an occipital transverse position that reduces the descent. And the passage, the pelvis can be contracted, or the soft tissues can impede the passage of labor. What are the risk factors for labor dystocia? Premature rupture of membranes. As you know, if the cervix is not well effaced, dilated, that can be a problem. Nulliparity, of course, because they have not delivered before. Induction of labor can lead to labor dystocia. They report increasing maternal age and also other previous complications, like if there was a previous perinatal death, pre-gestational diabetes mellitus, hypertension, and infertility treatments. Probably people would be more cautious with those ones for normal delivery. The second stage of labor, you are supposed to monitor the heartbeat of the baby every 5 minutes with each contraction, and you encourage the mother to push with contractions. In nulliparous women, delayed pushing or passive descent is not necessarily associated with adverse perinatal outcomes. And I'm sure a lot of you, occasionally you go there and you think the mother is in second stage, and you wait and wait and wait. The fetal heart is normal, but the baby doesn't seem to be coming out. And I'm sure you have a lot of that experience. And a risk of operative deliveries despite a prolonged second stage in nulliparous women. Delayed second stage, if there are skills for manual rotation of fetus, for instance, where these occipital posterior or transverse position at full dilatation, these are associated with reduced rates of operative delivery. Maybe you can tell me, I don't know how many of you are able to rotate in second stage fetuses in mal positions. When a prolonged second stage of labor is encountered, clinical assessment of the parturient, the fetus, and expulsive forces is warranted to assess those issues that we had said. Is it power? Is it a passage? Is it a passenger? Our famous fundal pressure of the uterus does not shorten the second stage of labor. I'm sure a lot of us in this place will disagree with me, but the term of obstetric trauma is applied to fundal pressure. So a prolonged second stage is, as I said, not associated with neonatal outcomes in nulliparous, although it's associated with increased maternal morbidity and mortality. When you have a prolonged second stage, you are more likely to have an operative vaginal delivery or indeed a cesarean section. If you have a prolonged second stage, watch out for postpartum hemorrhage. You are likely to have a third and fourth degree perineal lacerations, and you may also end up with peripartum infection. At delivery of the fetus, the mother can take the normal dorsal lithotomy position. This is the most common position that they deliver in. Although the delivery can be tried in lateral position, also called Sims position, or partial sitting or squatting position. It would be interesting to have the experience of this group and what positions, other than the normal dorsal lithotomy positions, you have delivered mothers and found to be useful. Episiotomies are now restricted to maternal or fetal indications. This was a drift from previously where episiotomy was almost considered routine for all mothers' delivery. Crowning is when the fetal head forcibly extends the vaginal outlet, and you can deliver that with a modified Röntgen maneuver where you drape a sterile towel. The heel of the clinician's hand is placed over the posterior perineum, overlying the fetal chin, and pressure is applied upward to extend the fetal head. The other hand is placed over the fetal occiput with pressure applied downward to flex the head. Thus, the head is held in mid position until it is delivered. Then you suction the oropharynx and nares. I need, after delivery, check whether the neck, the umbilical cord is wrapped around the neck, and you try to reduce it if possible. If it's too tight to be removed, you can double clamp it and cut. Some providers, in an attempt to avoid shoulder dystocia, deliver the anterior shoulder prior to restitution of the fetal head. There is sufficient evidence to support warm compresses to prevent perineal tears. The fetus anterior shoulder is then delivered with gentle downward traction of the head and chin, and subsequent upward pressure in the opposite direction will facilitate delivery of the shoulder. The rest of the fetus usually comes out very easily. If it doesn't do that, then you can clamp the cord and cut it. Then you shake the baby dry and transfer to the attendants or put in the mother's abdomen. Third stage of labor is after delivery of the baby, and the classic signs that the placenta is separated from the uterus is that the uterus contracts and rises, and the cord suddenly lengthens, and then you have a gush of blood. The placenta delivery should happen within 5 to 10 minutes after the fetus is delivered, but can stay there until even up to 30 minutes. Excessive traction should not be applied to the cord to avoid inverting the uterus. If you invert the uterus, as in the uterus becomes inside out, that's a medical emergency. The mother can go into shock, and she can have severe postpartum hemorrhage, and you do not want that. The placenta can be manually separated by passing the hand between the placenta and the uterine wall if there is delayed third stage. After the placenta is delivered, you check it for completeness, and just to ensure that you have not left any lobe in the uterus, and it should have one umbilical vein and 2 arteries. Oxytocin is administered throughout third stage to facilitate placental separation and induce uterine contractions. So a lot of us advocate for what is called active management of third stage of labor. Expectant is where you just allow the placenta to deliver on its own, but active management use oxytocics before the placenta is delivered. You clamp and cut the cord and do controlled cord contraction while the placenta is separating and delivery is awaited. They say that active management is superior to expectant management and should be routine management of choice. Concept of the fourth stage of labor is after the placenta is delivered, labor and delivery period is complete. You check that the mother's abdomen is, the uterus is well contracted and it is firm. If there is ongoing blood loss and the uterus is boggy, then that is an indication of uterine atony. You need to thoroughly examine the birth canal. That includes the cervix, the vaginal walls, the perineum, and the distal rectum. You need to repair all bleeding episiotomies, bleeding perineal and vaginal lacerations, cervical lacerations, and to expel clots. As we finish up, then we have the issue of pain control. A lot of us have been brought up with the notion that labor has to be painful. And I think we need to move to a stage where we control the pain of labor in our mothers. I think it is not fair. When people have a toothache, they run to the dentist at 100 kilometers per hour. But when our mothers are in labor, you do not offer them any pain relief. So laboring women would often experience intense pain due to the uterine contractions. This pain is a result in visceral pain, which is the innervation of T10 to L1, thoracic 10 and L1 innervations. While in descent, the fetus head also exerts pressure on the mother's pelvic floor, vagina and perineum. And now this causes somatic pain, which is transmitted by the pudendal nerve, which is innervated by S2 to S4. Therefore, to control pain during labor and delivery, then we should look at relieving the pain, both pains, visceral pain and somatic pain. So that is T10 to L1 and S2 to S4. Opioid agonists and antagonists can be given at intermittent doses for systemic pain control. A lot of the opioids that we use in that are available, so to speak, there are various types of opioids, but morphine is available, tramadol and pethidine are available in our institutions. A lot of us fear using opioids for fear of, addiction and all. But early in labor, when the labor is not intense and you are not fearing that the opioids may pass to the baby, then opioid agonists and antagonists are useful for pain control in mothers. It's therefore incumbent upon you to get naloxone to ensure that if a mother has had pain relief with opioids, then if there is an opioid issue in the fetus, then you have what is called naloxone as a remedy for the baby. But the aim of the opioids is to help the mothers with pain relief. Other centers, I'm hoping in the near future we may reach here, then would have regional anesthesia in terms of epidural, spinal, or combined. And these provide partial or complete blockage of pain sensation below T8 with the various degrees of motor blockade. That is the slight disadvantage of regional anesthesia in that motor action may also be compromised. And there is also a need for continuous monitoring of the mother during that labor. The adverse effects of regional anesthesia is that you can get maternal hypotension, especially if it enters the spinal fluid, fever, Post-dural puncture headache, commonly seen in post-CS mothers, but this can be reduced by using a very low caliber gauge needle. And I urge all of you to ensure that your anesthesiologist and anesthetist are using low caliber needles to avoid those ward rounds where you are having headaches of all the mothers in the ward. It can cause transient fetal heart decelerations and itching opioids, especially fentanyl. Other pain relief measures, and which a lot of our midwives and people working in maternities should venture into and develop it as a skill in Kenya, is getting relaxation techniques that our mothers can have so that they have pain relief during labor and delivery. Yoga, some say, may provide pain relief. Inflammatory drugs like brufen are contraindicated, especially in third trimester of pregnancy. Their repeated use may be associated with closure of fetal ductus arteriosus in utero, and this may decrease fetal renal function. So we generally avoid them. Just a quick note on what is called obstetrical triage. We cannot go through the whole obstetric triage because that's another CME on its own, but I picked out this obstetrical triage acuity scale from the London Health Science Center just to illustrate what triage may mean in a simple way. There are parameters on the left side, which include antenatal bleeding, fetal assessment, pain, hypertension, abdominal trauma, signs of infection, respiration, and substance use. And the triage levels are between level 1 and level. You want to triage your patient between level 1 and level 5, whereby level 5 is reported as non-urgent, and level 1 is where you are resuscitating a patient. The aim of having a way to triage mothers in labor ward is to see who do you act on now and who can wait for even up to 80 minutes to work on. And when you have these parameters on the left, so we will just use one of the parameters to illustrate the triage. So when you have labor, signs and symptoms of labor and fluid loss, and you have a level 1 is where you have to work on immediately, is where you have suspected imminent birth. And I'm sure you have seen those mothers who have come to labor ward in second stage, or a mother who has come with a cord prolapse. That has to be acted on immediately. Where you have less than 37 weeks and you have uterine contractions that are less than 5 minutes apart, and you have vaginal bleeding, and you can classify that as level 2 in terms of triage. An urgent 1, where you can wait for 5 to, you can do a reassessment every 15 minutes, is where you have a 7-week patient who is having contractions every 2 to 4 minutes. This is active labor in a 37 weeks. And if you have contractions of more than 5 minutes apart with vaginal loss and the mother is more than 37 weeks, that's less urgent. And if you have a mother who is cervix closed, requires cervical ripening, that is a mother who is non-urgent. So triaging is a way of ensuring that you have a way of screening which patients need to be acted on fast and quickly, and which patients can wait. And with that, I project a pathogram of a real delivery, just to illustrate some of the points that we have said. We can see that the pathogram contains the name of a patient, what the age is, the gravidity, the parity, a hospital number, a date, and we are using pathograms at from 4 centimeters as opposed to the previous ones, which were 2 centimeters. There is a plot for cervical dilatation. There is a plot for descent, and we have a plot for uterine contractions. As you can see, the mother progressed well, got strong contractions, which are 3 in 10 minutes, and delivered a nice baby. Then you have a summary of the labor at the bottom there. And this was a very successful outcome of a 35-year-old para 2+0 who came at 4 centimeters and progressed, and within 3 hours, she had delivered. So, and with that, I think those are some of the references that I had. And this topic of labor and delivery can go on forever. And I think I will stop at that, and we can have either a few questions or I hope you have learned something from the presentation. Thank you very much.
Thank you, Dr. Kigondu. We are a little bit out of time, but I think we're going to allow, let's say, 2 questions at most, and then we can end the session for today. Let's see.
Okay, there was a question. There are so many comments, but there was a question from Wakio Patterson about the labor care guide. I think he meant the new pathograph that's starting at 6 centimeters. So there's a question as to whether it's in pilot stage or it has been effected.
So there was the pathogram that we are using actually starts at 4 centimeters. And of the latest one is the 6 centimeter pathogram. But I think the ones that are circulated currently are still the ones with 4 centimeters, as opposed to the ones that were starting at latent labor 2 centimeters. But I think we will be moving soon to the 6 centimeter pathogram. 6 centimeter pathogram. All this is in an effort to reduce the number of cesareans done as a result of not really starting at the correct labor, active labor time. I've seen a session, one asking, Eric Musa was asked that we could organize another session on CTGs. I think that will be bookmarked, and Winnie will take note of that. And in our next series, we will definitely have a cardiotocogram session.
So Dr. Simon, there's another question on, do we confirm descent by palpation or VE?
Yes, actually, that I've seen, that's the one I was seeing. And yes, thank you, Jane Trix, for that question. And we confirm descent by both. As we have seen in the Leopold maneuver, there's a way of knowing the descent. And in the digital examination, the distance from the maternal ischial spines is also confirms descent. So descent from VE is described as +5, 0, -5, and the descent from the palpation is described as fifths, 1/5, 2/5, 3/5.
There's another question on the best way to measure blood loss.
Yeah, measuring blood loss is a study that has been going on for long, and many people have used many ways. And I think there is no real best method. It's a lot of people estimate, but there are people coming up with devices to actually measure blood loss. Watu wanaangalianga sheets wanasema hiyo damu ni mingi, it's a lot of blood loss. Others use the number of goes changed, and it would be interesting to know in your various units how you measure blood loss, and maybe someone can actually do a study on the best way of measuring blood loss.
Dr. Doris and Dr. Rolex, if you have any questions, we see your hands raised.
Hello. Okay, thank you so much for the presentation. I had a concern on predisposing factors to the late second stage, or maybe the risk factors. Can you consider like a short code as one of the risk factors or other predisposing factors, and maybe congenital abnormalities there, like maybe like autocephalus? Then the other question was on the let me think about it. The other question was on like in general, when we talk about artificial rupture of membranes, in practicality, we've been told that maybe membranes, bulging membranes, help in the dilatation of the cervix. But at the same time, we are told like we're not supposed to rupture the membranes unless we are concerned about the fetal distress. When there's a problem with the fetal distress, we may maybe rupture the membranes to check if there's meconium stain of the liquor or not. So I don't know which one, which some nurses or midwives will tell you that when they rupture membranes, it does to speed up labor. So maybe some highlights on that. Thank you.
Thank you very much. I'll go straight to the question of artificial rupture of membranes. In a lot of in active management of labor, a lot of times we used to be very aggressive in terms of doing artificial rupture of membranes, putting up syntocinon to allow the delivery to occur quickly. There are also schools of thought where we leave the mother to labor with the membranes, especially if the membranes if the engagement has not occurred. The reason for this is the danger of cord prolapse. The most common cause of cord prolapse is actually artificial rupture of membranes, and therefore it would be useful to actually allow a mother to labor for some time before doing artificial rupture of membranes. The advantages to artificial rupture of membranes in that you can also identify meconium stained liquor early enough. So it's a judgment call on the person who is conducting the labor and delivery. And a lot of people, there is no right or wrong answer. Some people, sometimes it is okay to rupture membranes early. Sometimes you can leave them to continue with membranes. Yeah, and part of the reason of moving away from the 2 centimeters to 4 to 6 centimeters was that you see, once you start doing vaginal examinations too early, and you may be tempted to do artificial rupture of membranes and augmentation, whereby labor may not have set in. Yeah. Anyone else could also contribute to that. Okay, I've seen a lot of requests for the slides. We'll share the links to that, and it's good that you have sent your email addresses. We'll also share the points, CPD points for the various teams, and we'd also want to have your feedback on both the session and improving the practices of labor and delivery in our area. We are working towards having better labor and maternity teams operating together. evidence-based deliveries, and this will be useful if we are collecting data from our facilities and giving feedback in such presentations. A good question from Christine Oyuga: is it right to augment labor with oxytocin before rupture of membranes? Use of oxytocin before rupture of membranes is not augmentation, it is actually induction of labor. And when labor starts, use of oxytocin without rupture of membranes can lead to pulmonary fluid, can lead to amniotic fluid embolism. So it is not advised. Yeah, I think all the questions, Enoch, are finished.
So Dr. Simon, we will check if there's some unanswered questions and we'll try to post it on the WhatsApp group so that you can address.
Okay. That is good. I think we usually try to maintain 1 hour, and I suppose we've just gone over. The topic is a bit heavy. So I think with that, we can call it a day. And we invite everyone to the next session, which is on Monday at between 7:30 and 8:30. Thank you very much.
Thank you everyone for attending today's session. We will also be sharing the link to the WhatsApp group via email to all of you so that you can be part of continued discussion that for answering questions and getting your queries solved. So thank you everyone. See you all on Monday now.
All right, goodbye. Thank you.
Goodbye. Good night.